Next speaker, Dr. Sriharsha, LANKA.
Can I have the presenter's view on? Yeah, thank you so much.
Do we have Dr. Hirika there? Right.
Okay, very good morning to the August House. I bring greetings from Port Blair. As we all know, orbital compartment syndrome can have devastating outcomes through compromised vascularity and compression of optic nerve. The common causes include intraorbital hemorrhage, tumors, and thyroid eye disease. However, I stand before you to present a rare cause of orbital compartment syndrome and even more interesting progression in this particular case. Our patient is a 55-year-old gentleman who was a father of service soldier who initially underwent an uneventful cataract surgery in the first eye. He was operated in the second eye with pre- and intraoperative period being uneventful. However, on post-op day 1, he had severe headache and ocular pain, proptosis, chemosis, and limitation of extraocular movements with visual acuity of 6/60 with RAPD being present. Within the next 20 minutes, the patient had rapid deterioration to just perception of light. That's what his vision. And this was the eye appearance. And with a clinical impression of possible retrobulbar hemorrhage, he was taken up for an urgent CT scan and shifted into the gantry of CT within the next 10 minutes. To our surprise, there was no blood in the orbit on the CT scan, and positive findings included proptosis and posterior tenting of the globe. While a CT scan was being acquired, his vision further dropped to no PL inside the CT gantry. Sensing an ongoing active rise in the intraorbital pressure, he was immediately shifted to the OT for decompression. In the OT, immediate lateral canthotomy and cantholysis were undertaken. This led to a dramatic on-table return of PL while the patient was still on table, and the patient confirmed that the light had returned. Within a few hours, the acuity improved to 1/60 and remained so for throughout. He was admitted and managed with high dose of intravenous steroids, topical moxifloxacin, IOP-lowering drugs, lubricants, and homatropin. The corneal edema, which the patient had resolved over next 4 days, and it is when we noticed CRAO in the patient. He was given all possible measures to control CRAO, which was too late by then. However, he was also offered hyperbaric oxygen therapy of 4 sessions, which yielded no response. However, we see in the patient that there was a return of PL, gradual reduction in proptosis, and some visual recovery. However, the enigma remained why the in the absence of retrobulbar hemorrhage, what caused the such a severe orbital compartment syndrome. So literature was reviewed, and a probable hypersensitivity to local anesthetic mixture was considered, and the patient and his family were counseled for hypersensitivity testing. We waited for 8 weeks so that all the steroid in the system is metabolized, and intradermal prick test was done. For the test, the volar aspect of his left forearm was injected with normal salinous control, plain lignocaine, and mixture of lignocaine and hyaluronidase. In this particular patient, bupivacaine was not used by the resident who blocked the case because it was unavailable. The same stock of both drugs were used for testing as used preoperatively. Until the time the testing in this suspected case was used, we seized all this particular batch of drug, and we didn't use in any other patient. 10 minutes post-patient, it was injection, it was evident that the culprit was indeed hyalase. It can be from bovine, ovine, or recombinant human source. The incidence of allergies is known but very, very rare. It is commonly used in ophthalmology and intra-articular and caudal blocks injections. The presentation can be acute, early, intermediate, or delayed. The presentation may simulate in a variety of different presentations also, and it is thought to be of type 1 or type 4 hypersensitivity. To conclude this case, we've come to know that hyaluronidase allergy can have devastating sequelae. Primary sensitization, as in this case, through the first eye, might have been a trigger in the second surgery. Though the benefits of the drug usage outweigh the risk, we have to be extremely suspicious in such kinds of presentation in post-operative scenario. The importance of this case is we owe the answers to the patient, and if possible, hyalase should be avoided for regular use, especially in this age of topical surgeries. This was, of course, a resident case, so we did use it. And meticulous documentation may protect against any litigation in such scenarios. These are my references. Thank you so much.
Thank you.
So the surgery was done under peribulbar,
Yes, sir.
right? And the patient was patched,
Patient was patched
and it was opened the other day, the
other
next
day.
day.
Yes, sir.
And there was vision when the patch was opened.
There was vision, sir. In fact, it was continuously dropping. We somehow explain it by the patch was somehow preventing any edema due to external pressure. When it was opened, it was in the range of 636, 660, and over the period of minutes, he started decompensating.
A little unusual.
Unusual, sir. So I went through a few articles. They told that in the articles it is known that it can evolve over a period of few hours also. So maybe overnight it was fine. Early morning onwards, he started having headache and periocular pain.
Right.
That was the reason to present this because it's quite unusual and even the most dramatic aspect was the moment we did cantholysis. Patient said within 1 minute, sir, मुझे OT का light दिख रहा है. So that was something.
So maybe there's an allergic reaction to, I mean, it's usually acute or subacute most of the times.
Yes, sir.
So maybe there could be.
It might have been evolving overnight, and it was lucky that we could spot it.
Maybe could have been some other reason as well. Maybe.
So it was not noted in other patients of the same OT.
Right.
There was no skin reaction.
Correct.
It was not betadine. It was not Tropica Plus.
Right.
And that is why the skin testing was there in presence of the HOD of the dermatology department.
Right.
So
Maybe something like an insect bite or something like that. Some other cause.
unusual. It was patched eye. So the eye was patched overnight. So
Yeah.
very unusual, and that too in the only operating eye. CRAO presenting. It was really a compressive neuropathy.
Compressive. Right. Right. Right.
Yes.
Thank you so
Thank you,
much.
sir.